So interestingly, I started my journey as an educational and developmental psychologist, and through a couple of opportunities of happenstance, my background then shifted into medical and surgical education. I started looking at continuing professional development, so how to support physicians over the lifespan of their educational opportunities. Moved then into surgical education, which also included orthopedic education. And then I shifted into faculty development. So at the University of British Columbia in the Faculty of Medicine, I led the faculty development office, which supported all educators from basic scientists all the way to clinical applications. And I also led the curriculum redesign of the medical undergraduate program. All of that really embedded me in understanding how an educator can go into a clinical education world and medical education world and start to ask interesting questions. So some of the challenges that I think face surgical education are the fact that what we see over time is really the idea of excellence, efficiency, and expedited clinical practice. And so the idea of the healthcare system starting to really speed up in the efficiency and how they expedite support for patients is not always the best support for education. So for instance, if you think about 15 or 20 years ago, you might have an orthopedic patient who's having a knee replacement who would spend multiple days in the hospital, which meant that residents and fellows had a lot more time to navigate through their own educational journey because the patients that they worked with were there. The challenge now is if you think about that same surgery and it's a one-day outpatient or very short duration stay in hospital, that educational opportunity for residents and fellows to really navigate through what they're learning becomes much more challenging. So I think one of the things that has changed over the last 5 to 10 years for the surgical educator is really understanding how to step back and reflect on that educational journey for residents, medical students, residents, and fellows. The challenge historically has been that a lot of the mentorship, the traditional mentorship model has been that idea of follow along with me, watch what I do, learn from me, learn to become me. And I think the current system doesn't allow that in-depth connection, the longitudinal relationships. So I think the modern surgical educator really needs to think about their identity as educator, how they're intersecting with the learners at different points in time, and that it's not a longitudinal relational journey. And so I think that means changing the approach, changing the support, changing the faculty engagement and faculty development to really support the new learning opportunities. I think the other major challenge that we've always faced is the changing, what I would call socio-historical landscape. So what happens is education changes in the formative years for learners. And the challenge then is how are educators keeping up with those changes? So a little bit about my background in surgical education actually started before I came into a faculty of medicine. And that was that I was very interested in educational development and educational psychology. So one of the projects that I have supported all the way through my academic journey is to look at professional identity formation. And I had an opportunity when I first worked in the Faculty of Medicine to look at the educational support for continuing professional development. That led me to an opportunity to work with the Department of Surgery to really think about the education of their residents and the medical students that came through those programs. that extended then into orthopedic education, and those are areas that I still continue to work in. The idea then is, as an educator in medical education, without the surgical or clinical background, I have the opportunity to ask the interesting questions that lead to meaningful changes in the educational environment. So I think one of the things that I am always interested in looking for is really seeing those fundamental changes in education, those tectonic shifts that happen. I think now we are really on the precipice of understanding how to embed technology, and not just passive technologies, but active technologies, generative technologies. And so I think one of the things that I'm really interested in making the connection with PrecisionOS is to understand how technology as a tool can be embedded in education, and how that embeddedness creates those innovative changes for the current and future students, medical students, residents, and fellows. I think that we have to really think very differently about the fact that technology is not just being shouldn't just be layered on. It needs to have an understanding of how we can support fundamental integration. It's a really great opportunity to bring together a group of like-minded individuals who want to start to dig into these big challenges around simulated education and virtual reality. The idea then is that you can bring together, for example, program directors who really want to understand how they can embed this kind of technology and wrap it around the appropriate level of learning and education and program design to be able to then adapt it to their own contexts. So what ends up happening in those instances is the ability to partner together to understand how to create the first opportunities to look at embedding this kind of education, but still then being able to take it into their own learning context and adapt it into their own environment. And so it goes back to a comment that I made, that this idea of the partnership really then helps speed up and create the opportunity for that cross learning. So in that way, you're not isolating the opportunity to really think deeply about this. The other thing that I think that this Council on Residency Education can help with is not only understanding the opportunities for this, but really understanding the barriers and challenges. There's never an easy way when we start thinking about innovation in education. There are always things that we have to think about in terms of those barriers. The idea then is to have those fulsome discussions to understand where the opportunities are, where the challenges and barriers exist, be able to group think about what kind of solutions work in the more general as well as in the more specific contextual ways. And instead of just simply layering on, which tends to be the traditional way that we think about new educational initiatives, it gives us an opportunity to think more deeply about how to embed these kinds of things into the fabric of the residency education programs. I think it has the opportunity in the council's mandate to really start to step back and think more deeply and more educationally focused on technology applications. I think it has the opportunity in the first instance, in the first 1 to 2 years, to think about that in the landscape, specifically about virtual reality training. But what I think it also offers in the longer term is the opportunity to think about all the technologies that we don't even know about that may be coming on in the future in the simulation space, to create a blueprint for that changing landscape, and really be able to look at it, step back, understand the educational benefits, identify the challenges and barriers, look for those solutions, create champions, and really start to move the conversation forward. I think the first priorities to focus on as the chair of the council is to understand and come together on what are the opportunities, where are the problems, and what is the educational application that can really help support the idea of embedding virtual reality and simulation into resident education. I think as a non-clinician educator, PhD trained educator, I have the opportunity to ask the interesting questions from outside the community and the culture. I think together with those that are really trained within the culture, the surgical educators, the orthopedic educators, the residency directors, is really coming to an understanding of how education and innovation in education can support simulation training and education and make it so that it is not simply the add-on, but it actually addresses real world, current and future medical education problems. I think the one thing that I would change in thinking about resident education today is understanding that we move between two things. We move between competence and identity. And so the idea of resident education is that competency, so the knowledge and skills, is the necessary but not sufficient condition to being able to move somebody along from not being a surgeon to being a surgeon. I think one of the other things that's incredibly important in that journey through residency is understanding the being and becoming. So how are individuals becoming surgeons? And then as they transition in that critical transition between the educational system and their practice, how are they being and continuing to develop as surgeons? And I think that when we think about lifelong learning, we really have to think about those critical transitions. We have to pay attention to the fact that individuals that are navigating through this system are always trying to wrestle with what they are doing and who they are becoming. So I think the way to think about VR programs and simulations integration into surgical education and medical education is really to find those foundational opportunities. As I said, it can't just be an add-on. It has to be integrated. It has to be longitudinal. It has to be developmental. And so one of the things when you think about the developmental trajectory of an individual's education from medical student through resident, maybe into fellowship, and then into practice, the idea is that the virtual reality and simulation has to support that developmental trajectory. It has to be able to start simple. It has to be able to be embedded from very early on, and becomes second nature. It just becomes another learning opportunity. It is beyond just being a tool, but it becomes an educational platform. And then as individuals grow and change over that educational trajectory, the virtual reality and simulation needs to grow and change with them. It has to be able to be adaptable to the situation, and we have to understand how it fits within the context of residency programs. Not every residency program is the same, so you also have to understand how that adaptability works. You have to think about embedding it foundationally. One of the challenges is really that if you only ever layer it on top, that you need then a champion to keep promoting and keep supporting, which is very different than being able to integrate it into the system. If you can integrate it into the system of education and it becomes second nature to the program and the people in there, then I think that you have a level of success that can support it long term. So I think the signals that I would look for to really see that that simulation and virtual reality is working within a residency program, for instance, is really on what I would look at as 4 levels. So the first level, and this really is one of the evaluation frameworks called Kirkpatrick's, is satisfaction. So really understanding how those that use it and those that implement it are satisfied with the tool, the technique, the education, the support for both students and faculty. That creates a motivation. So if individuals are happy with how it is working, then they may be more motivated to be able to use it. Then you have to move into the next layer, which is learning. So do you see that this changes something in the learning environment for the individual or for the program? What happens? How is that learning changing for them? How are they becoming more adept at the things that they're practicing? If we just stop there, then I don't think we'll achieve the success that we are really striving for. I think the next layer then is the behavioral changes. The idea that you start to not just see they learned it, but they're starting to apply those things in other practice settings. So it's the transferability and the generalizability that you're starting to move, which is always what we look at in the simulation space, is how are they then using what they're trying out in the simulation space to really apply to real world practice. And then the final level is the systems change. So how do we see that the long-term goal is that it becomes embedded? As I said, it becomes second nature. It becomes developmental, longitudinal, and it has the adaptability to change as the educational environments change over time. So I think what we understand in the educational landscape is that educators constantly feel overwhelmed with all the things that are changing constantly. And we understand that the speed with which those changes are happening is getting faster and faster and faster. And so what we understand 25 years ago was we had years to think about how new innovations were coming in to change. And then I think what happens is that surgical educators, for instance, started to feel that you had months in order to contemplate changes. And now we think that those kinds of things are speeding up so much. So I think one of the challenges is how to leverage that idea that it takes a group, it takes that cross-organizational thinking, it takes the support of others to really start to look at surgical education. It isn't just we can do this in our own environment for ourselves all the time. The idea is then those consortium models really help explore, innovate, and really start to accelerate those opportunities to change. That ability to have that transdisciplinary and cross-disciplinary opportunities. So educators, technologists, surgeons, all the other individuals that need to be involved. And so the biggest thing is how to leverage those opportunities. It isn't just the single individual having to make the changes in their own practice, in their own educational context. It's about creating those support networks so they can do what they do best and we can be there to support them. So I think what excites me about the next chapter of my work, specifically in surgical education and really partnering with PrecisionOS, is to change the narrative that it isn't just a technology, it's an educational innovation. And that educational innovation will lead to real change. That we understand that as we are doing these things in simulation and virtual reality and beginning to embed it in the residency education, fellowship education, even moving back into medical education, the idea then is how is that creating an opportunity to change the way that we educate the future physicians who are going to come into a new practice. One of the things that I always think about in education is that we don't want to just sit back passively and try to divine what the future is. We want to be active and start to define what the future is and how the educational practice and supports that go into that really change the way of the way that physicians practice now and in the future. The idea then is, how do we take hold of those technologies, wrap them around educational innovation, and make real fundamental changes in clinical practice? I think one of the ways to define success for the council and its impact on surgical education is really something that I call the educational invisibility factor. And what I mean by that is, if 5 or 10 years down the road, nobody questions that this is just the way we do things, and that it becomes invisible and embedded, and it becomes supportive, and it really does become just second nature, I really feel like that is the goal.